Everyone, and welcome to this explainer on iron metabolism and iron deficiency anemia. This is a super high-yield topic, not just for your MCQs, but for your future ward postings too. We're going to break down these complex pathways into very simple logical steps. So let's get right into it.
But before we jump in, I want you to keep this crucial question in the back of your mind. Why exactly do we rely on serum ferritin first when we evaluate a patient? What's the actual mechanism there? Keep thinking about this as we go, and we'll crack the answer together very soon. Here is our roadmap for today. We'll cover physiology and dietary sources, the iron absorption pathway, bone marrow and iron indices, stages and causes of IDA, clinical features and smear, and finally, diagnosis and treatment. Starting right off with Section 1, Physiology and Dietary Sources. Let's clear our basic fundus first. So looking at total body iron, it's roughly 50 milligrams per kilogram in males and slightly lower, around 40 milligrams per kilogram in females. Now, put a huge star mark on this next point. A whopping 67% of this iron is bound directly to hemoglobin. About 27% makes up your storage iron, and just a tiny fraction is circulating as transport iron. Understanding this distribution is absolutely essential. To make the storage part perfectly clear, let's compare hepcidin and ferritin. Notice how ferritin is water-soluble. Because of this, it's highly available, making it our body's primary storage protein. Hepcidin, on the other hand, is water-insoluble. It basically clumps up inside your macrophages, so it's far less available when the body needs it. Naturally, your body's going to prefer ferritin for a quick iron supply. Moving to Section 2, the iron absorption pathway. Let's see how iron actually gets from your diet into your enterocytes. You need to understand this difference perfectly because it's a classic MCQ concept. Heme iron, which you get from chicken and meat, is already in the ferrous state. That's Fe2+. Because of this, it is completely set for direct absorption. It's very efficient. But plant-based non-heme iron, like what you'd find in spinach, is in the ferric state, Fe3+. It literally has to be reduced first by duodenal cytochrome B reductase to become Fe2+. Remember this rule. Absorption happens mainly in the ferrous, Fe2+ state. Now, this brilliantly illustrates the luminal membrane of the duodenum, where this whole magic happens. This is a very heavily tested diagram. Look closely at the enterocyte, the cell lining your gut, and just notice the different channels sitting on the luminal surface facing the food and the basolateral surface facing the blood. Let's break that complex process down step by step. First, we have the reduction of Fe3+ to Fe2+. Then, that Fe2+ enters the cell via DMT1. That stands for divalent metal transporter 1. Finally, to actually get out of the enterocyte and into your circulation, the iron exits via ferroportin 1. Now, there is also a regulator here called hepcidin that can block this exit, which is super important in the anemia of chronic disease. But for normal physiology, this simple three-step pathway is exactly what you need to memorize.
All right, Section 3, bone marrow and iron indices. Once it's in the blood, where does it go?
It gets transported directly to the bone marrow. Iron is taken up into the marrow via transferrin receptors and moves straight into the mitochondria for heme synthesis. And this brings us right to the gold standard blood parameters we check in the lab, our critical iron indices.
What's really fascinating here is the interplay between these values. This table is a strict must-know for your exams. In deficiency, ferritin and serum iron naturally drop. But your body, right, it tries to compensate. It thinks, hey, I need more iron. So it actively increases the total iron binding capacity, or TIBC, by pushing out more transferrin. So the golden rule is iron goes down, TIBC goes up. Additionally, the soluble transferrin receptor increases, making it the absolute most sensitive marker for tissue iron deficiency. And coming back to our opening question, why is serum ferritin the earliest marker? Because the body will always deplete its storage iron, the ferritin, way before it ever lets those circulating hemoglobin levels drop.
That brings us to Section 4, stages and causes of iron deficiency anemia. As you can see, a patient doesn't just wake up with severe anemia. It happens in 3 distinct stages. First, a pre-latent negative balance, where only your marrow iron and serum ferritin drop. Next, a latent stage, where erythrobicesis itself becomes iron deficient, but the overall hemoglobin is somehow still maintained. And finally, stage 3,
This is true iron deficiency anemia, where hemoglobin actually falls, giving you that classic microcytic hypochromic picture.
Now, when evaluating etiology, never ever forget this clinical pearl. Chronic blood loss is the primary cause of iron loss unless you can prove otherwise. You absolutely must rule out GI bleeds, heavy menstruation, or hemorrhoids. We also see malabsorption causing this, particularly in celiac disease. Think about it. Iron is absorbed in the duodenum, and celiac heavily damages the duodenum. Makes perfect sense, right? Also, keep increased demand from conditions like chronic kidney disease in your differential.
Let's move to Section 5, Clinical Features and Smear. What do these patients actually look like in your clinic?
Observe these classic epithelial lesions. This is exactly what you must look for on your physical exam. You'll see angular cheilitis at the corners of the mouth, a very smooth atrophic glossitis on the tongue, and if you do a barium swallow, the characteristic esophageal webs of Plummer-Vinson syndrome. These patients will classically complain of dysphagia, so watch out for that.
Once you make the diagnosis, you obviously need to fix it. You literally have to mug up this specific formula. Iron deficit equals 2.3 multiplied by the desired hemoglobin minus the patient's current hemoglobin multiplied by their body weight plus 1,000 milligrams to replenish those stores. You are going to use this calculation routinely in the wards for sure. Let's look at the peripheral smear carefully. This is your classic microscopic picture. You can easily spot obvious pencil cells, teardrop cells, and just striking hypochromia. Look at how massive the central pallor is in those red blood cells. They practically look like empty rings. There is also anisopoikilocytosis, which is just a fancy way of saying unequal size and shape of the RBCs. Because of this, your RDW, the red cell distribution width, will be elevated. And here is a super simple trick for your exams and daily practice. Both iron deficiency and thalassemia trait give you a microcytic hypochromic anemia. So how do you quickly differentiate them? Use the Menser index. It is simply the MCV divided by the RBC count. A value greater than 13 points squarely to iron deficiency, but if it's less than 13, you need to start thinking about thalassemia trait.
Finally, Section 6, Diagnosis and Treatment. Let's wrap up patient management.
Now, while our Prussian blue stain showing absent marrow iron is technically your definitive gold standard test, it requires a bone marrow aspiration, which is obviously very invasive. So in our daily practice, we don't jump to that. We usually start treatment based on our non-invasive iron indices and whatever stage of deficiency we've identified.
Treatment is pretty straightforward, but it highly depends on patient compliance. You'll prescribe oral iron, like 200 mg ferrous sulfate 3 times a day for those latent stages, and crucially, you must continue it for 6 to 12 months after the hemoglobin corrects. Why? Just to rebuild those depleted storage levels. However, you're going to shift to parenteral IV iron, like iron sucrose or ferric carboxymaltose, for advanced stage 3 deficiency, or honestly, if the patient just can't tolerate the oral iron because of severe gastric side effects.
I want to leave you with this final, very important thought for your clinical practice. Are you just fixing the numbers on the lab report, or have you actually investigated the root cause of the iron loss? Think about it. If a 60-year-old male comes in with iron deficiency, giving him iron sucrose is not going to cure the underlying colon cancer that's bleeding into his gut. You always have to act like a detective. Thank you so much for joining me in this explainer. I hope this cleared your fundus perfectly. Keep studying hard, and I will see you all next time.